Here's a little bit of interesting trivia. The first mention of this in any medical journal was in 1902, and the diagnosis that this physician came up with, he called it defects in moral code. It's probably not going to be in DSM-5. I don't think they're going to go back to that. But, over the years, they call it minimal brain dysfunction, hyperactivity, and so, they've used different terms to describe it. But the thing that's really cool about this is, number one, he described the behavior exactly like it's in the DSM. Okay, so I mean, he really was able to say, hey, here's a syndrome, and here are the characteristics, and he was right on the money. Secondly, he said, it seems to occur more in boys than girls, and that's probably the case. Okay, and finally, he speculated that this was due to some kind of brain dysfunction, and his rationale for that was that you can have extraordinarily severe symptoms that can really cause lots of problems for these kids, and yet many of them come from families that are good, normal, healthy, functional families. Most kids that have schizophrenia, their families are really messed up too. So if you look at really major mental illnesses, a lot of people are coming out of family situations that are highly dysfunctional. But the thing about this that really is the trivia part of it is here this guy is writing about hyperactivity, and his name was Dr. Still. Again, one of those very important bits of trivia I'm sure you'll remember for the rest of your career. And then there was some additional stuff that came along in the early part of the 20th century that kind of lended to support the notion maybe it's a brain problem. There was a big epidemic of encephalitis in, I think it was 1917. It killed lots of people, millions of people worldwide. But after it subsided, some of the people that survived had all these symptoms that looked exactly like these kids, or real similar to that. So that suggested that. Benzodrine really was the first synthetically produced stimulant. Came in the 1930s, and back then they could do research on kids without any permission from like ethics boards or parents or anything. And what they started doing is they had all these kids that were like in reform schools, because they were bad kids. They tried all kinds of stuff on them to see if it worked, and it didn't make any sense. A lot of these kids were wildly agitated and aggressive, but eventually they given them all kinds of stuff, They gave them some of this and they calmed down. It's like, whoa, maybe we're on something here. Okay. Soft signs, these kids have higher incidence of very subtle neurologic signs. Prevalence rates, now more recently, it's probably closer to the 7, maybe even 8%. There's going to be some new epidemiology studies that are planned once DSM-5 is out, so we'll kind of go back to the drawing board. 4% of adults, and the reason 4% rather than 7% is because study after study has shown that about a third of ADHD children in late adolescence, early adulthood, completely outgrow the disorder. And this corresponds to the later stages of development of frontal lobes, and frontal lobes are really good at doing lots of stuff, like, for instance, controlling impulsivity, helping to focus attention, and so on and so forth. So more than half of ADHD kids are going to be ADHD teenagers and go on to be ADHD adults. Now, we're going to see the clinical picture changes a little bit over time, but they still have it. I tell you what, actually, just forget this, okay? When I say acquired, this is not true ADHD, but there are lots of kids who have they have fetal drug exposure, they have problems with during delivery, labor and delivery, and they've had head injuries and so forth. They look like ADHD, but the underlying pathology is different. Okay, so the vast majority of true ADHD is at least presumed to be genetically transmitted. Now, this is really important, and this is going to be addressed. It's being debated now. It's going to be addressed in DSM-5. And it has to do with subtypes of ADHD. So if you take a look at, we'll assume that 100 represents 100 kids that have the real thing. And we'll say there's a lot of other disorders that may, at least at first glance, look like ADHD, but they really it isn't. So if you take 100 kids, most of them, probably 90% of them by adolescence, the H drops out. So the wiggling and can't sit still stuff begins to evaporate. But the core symptoms, which are impulsivity and deficits in intrinsic motivation that I'll talk about here in just a few minutes, will continue to be prominent, okay? Now, here's the important thing, and that is a lot of these kids are diagnosed when they're children, okay? But there are people that get diagnosed, you know, in high school or even in college sometimes, and they don't present with the motoric restlessness and hyperactivity part of this, but they are not ADD. They don't deficit disorder. What they really have is they have ADHD minus the H. Now, the reason I'm making a big deal about this is because there is what currently is called the inattentive subtype of ADHD, and it's absolutely clear it's not even related to ADHD. Okay, the underlying biology is different, the response to medications is different, and so forth. Okay, so this is going to, I don't know what the final outcome is going to be, but they're going to have a qualifier, a subtype of adolescent version that says it has the core symptoms minus the hyperactivity. Okay, now I'm going to elaborate on this, the inattentive subtype here in a few minutes, and then by adulthood you can see about a third they completely outgrow the synchronous.